Realizing universal health coverage, a path to hepatitis elimination. My name's Richard Jones. I'm editorial director at Devex, and I'd like to thank our partners. This event has been sponsored and convened by Gileads Sciences, Inc., Harvard Medical School Program in Global Primary Care and Social Change, Coalition for Global Hepatitis Elimination, and the World Hepatitis Alliance. I'd like to thank all of our partners for their generous support in helping us put on this evening's event, live from the World Health Assembly here in Geneva. Now, viral hepatitis, it's an infection that causes liver inflammation and damage. It often flies under the radar in global health circles. One person dies from viral hepatitis every 30 seconds. That's over 1 million deaths per year, a toll that's even greater than HIV and malaria combined. To address this often hidden health crisis, the World Health Organization has set a global target to eliminate viral hepatitis by 2030, including diagnosing 90% of people with hepatitis B and C. Still, a lack of awareness and political commitment, as well as stigma and discrimination, continue to pose significant barriers for people when it comes to accessing testing and adequate care. There is some good news, though. Advances in hepatitis care and treatment have drastically improved over the past decade, including the development of direct-acting antivirals that can cure chronic hepatitis C, and the rollout of hepatitis B vaccines at birth. Now, tonight we've convened a very special, unique group of experts to unpack what's needed to eliminate the barriers to universal hepatitis care, as well as the role of multi-stakeholder partnerships in advancing better access. We'll also hear some important lessons learned from Vietnam and the Philippines, two countries with high burdens of hepatitis B and C. So without further ado, I'm going to introduce Dr. David Duong, Director of the Program in Global Primary Care and Social Change at Harvard Medical School, who's going to help us set the scene tonight. David, over to you.
Thank you so much, Richard, and thank you so much, everyone, for spending your evening with us. We know there's a lot of competing events, so thank you so much for coming. On behalf of Harvard and our convening partners, the Coalition for Global Hepatitis Elimination, Gileads Sciences, and the World Hepatitis Alliance, thank you so much. We hope that this will be a really exciting evening of discussion around the intersection of hepatitis elimination, universal health coverage, and primary health care. Richard alluded to some very grim statistics, and I'll share a little bit more with you that, as some of you may know, if we continue the current status quo, global mortality from hepatitis will be expected to exceed that of HIV, tuberculosis, and malaria combined by 2040. And compared to those three diseases, hepatitis-related morbidity and mortality are still increasing. Unlike our approach to HIV, TB, and malaria, which utilize targeted vertical programs, we have a big opportunity with hepatitis elimination here to use an integrated approach within a UHC framework while simultaneously strengthening our primary healthcare systems. Hepatitis was included in the 2019 UN high-level meeting on UHC declaration, as well as in SDG 3.3, where member states have committed to hepatitis elimination in their health and in their UHC programs. Our opportunity here today is to offer insights, recommendations, and tangible actions to accomplish this through collaborations between researchers, healthcare workers, policymakers, and patients to ensure that the right care is provided at the right time, at the right place. So this evening, we're going to really try to center our conversation around what we would like our patients and their families to ultimately experience while they're seeking care. At these global convenings, we tend to focus on the big numbers of global morbidity, mortality, and disease prevalence. But we know that at the end of the day, diseases affect individuals and their families on a very personal level. So one of these people here today, and we're so lucky, is to have to have here today is Miss Joshi from the Philippines, who will, for the very first time, be sharing her experience of living, of a person living with hepatitis in the Philippines. And then Dr. John Ward will lead us in a really diverse panel discussion from the global to the subnational level to talk about strategies on hepatitis elimination within a UHC framework utilizing primary health care. And finally, we're going to end with specific call to actions that each one of us can take on an individual as well as on an operational level. So once again, I thank all of you for spending your evening with us today. And with that, I'll introduce Ms. Joshi to come to the stage and share with us for the very first time her story of living with hepatitis. Ms. Joshi.
Good afternoon, everyone. I'm Joshua Pakira, 34 years old, from the Philippines. And I once dreamed to travel the world and become a nurse. But here I am in front of you sharing my stories. I've known my hepatitis in 2005 prior to my internship to the hospital with my course nursing. I'm in complete shock when I learned that I have this hepatitis B. I don't know where I've got this. I don't know what is the next step. So luckily that day, I have my friend's mother, which is a doctor, that advised me to take a DNA test. But that time, it's very hard to have that test because it's 13 times of my daily allowance. So it took me 2 weeks to have that test. It took me 2 weeks to save up. And after that, I went to different doctors. And the doctor said, the hepatitis B is incurable. The hepatitis B is a lifetime. And he also added that in 20 years, I'll be developing liver cancer with which is a high mortality rate. I went home and I tell the result to my family. The initial reaction is separate my things, my utensil from their things and utensil. They even asked me to eat after them. So it really hurts that the discriminations starts from my family. But still, I convinced them to also undergo the screening. It took me 2 weeks to encourage them to have that screening. And sadly, 4 of my siblings is also reactive. We had this silent agreement that we have to keep it in the family because we are afraid of the discrimination we might experience within our community. So, and I finished my study in nursing, but it's very hard to find job that is related with my course. So whatever job they can offer, I accepted it because I need to raise money to spend for the college expenses of my other sibling. Years passed, and I met my husband in 2012. He never knows about my status, but I have him tested, and I have been tested and vaccinated for his protections. Until 2013, when I became pregnant and gave birth to my child, the day of my child was born, this nurse in the hospital gave a prescription of immunoglobulin to my husband. He doesn't have any idea. All the nurse said that he needs to buy that medicine to be administered to my son. So what he did is, he went to pharmacist to pharmacist. He was very confused that day. So he just went to pharmacist until he find it to another city. And after I give birth, he asked me, what is about that medicine? What is that medicine for? So I told him everything about my hepatitis B. Thankfully, he still accepted me and support me. But I know that is also the reason why he never asked me for another child, even though he has this dream for a big family. A year passed, my sibling graduated in college, and my responsibility become lighter. So also, but this is also the time that I feel tired of being alone, tired of being afraid, tired of self-pity. I'm also tired of thinking on, I'm also tired of thinking that in 20 years, I will be a burden to my family for developing liver cancer. So I decided I have to find a community with hepatitis B. That is the time that I found the Yellow Warrior Society Philippines. So I attended the seminars, the meets up, and their team building. Because of that, I feel that I found my safe place. It's also give me the courage to step up. It's give me also the reason to step up and speak for the community of Yellow Warriors Society of the Philippines. It's also in Yellow Warriors, we were given a chance to be a part of this study in early detection of liver cancer. From that study, the doctors explain every laboratory. The doctors answer all our questions. That is the time that I realized that liver cancer is a chance but not a fate. This gave me courage to do more and to be an advocate, to disseminate right information so my co-patient won't live in fear just like I've been in so many years. In January 2023, the program is ended, but luckily the government introduced a program in hepatitis B in partnership with HIV. There's a lot of challenges, but I know if we work together, we can come up to better solution. Another issues is the employment in the Philippines. There's already a memo in anti-discrimination, but there is no written law for the protection of the hepatitis B patient to be to get their dream job. I never imagined that I'll be in front of you today, but here I am, and I just want to ask, how long this situation remain? How many dreams have to be broken? I'm challenging you, all of you, to see us as a partner because I believe in collaboration with patients, government, healthcare worker, and private sector, we can do a massive change. This also empower the community with viral hepatitis. I may not used to this public speaking, but if this is the only way to hear our voices, may God bless me. Thank you.
Thank you so much, Ms. Joshi. It really does take courage to do that. So thank you for your courage to give us that story and to represent the over 300 million persons living with hepatitis B and hepatitis C. Over 80% of those are undiagnosed and totally unaware of their status and can't even share their voice because they do not yet know they have this silent infection. As David mentioned, I'm John Ward. I'm the director of the Coalition for Global Hepatitis Elimination at the Task Force for Global Health, which is a global health nonprofit organization headquartered in Atlanta, Georgia. It was started by former CDC directors where I worked for a number of years. And one of our guiding principles is as we look at these large global problems, always remember behind every statistic, behind every number, there's a face. And that's why it's so important to keep Ms. Joshi's story in mind, because that's the kind of situation we're seeking to improve. As we work globally, we want to have that impact individually. While I was at CDC, I was the director of the Division of Viral Hepatitis for many years, where I did a number of different things. I developed the first action plan on hepatitis for the U.S. and worked on developing a number of policies for vaccination, testing, linkage to care, and the programs to carry them out. And I bring them up now because I really value the engagement of civil society organizations and having that patient voice at the table to make sure that your policies and programs are well informed, they're going to be well received, and they're going to be targeting the populations most in need of those policies, programs, and services. And that brings us to our topic today. I believe hepatitis elimination and the pursuit of universal health care coverage have the same goal, which is health equity. We want to eliminate the disease for everyone in a community, a province, a country, and eventually the world. And universal health coverage is seeking universal access so people can have an equitable shot at good health. And I think that's what we're going to be exploring in our panel today. So let me begin to introduce those and get some other voices here up on the stage. If I can start with Dr. Meg Doherty, please, who's the director of the Department of HIV, Hepatitis, and Sexually Transmitted Infections at WHO. Welcome, Meg. Have Dr. Mohammed Hassani, please, who is the Health Minister Assistant for Projects and Public Health Initiatives in Cairo. He's also the director of the National Hepatitis C Elimination Program, and he's an associate professor in gastroenterology and hepatology at the National Hepatology Institute in Cairo. Mohammed, welcome. And we have Dr. Nika Howe, who is the Director of Disease Prevention and Control for the Ministry of Health in the Philippines. Welcome, Nika. That is, yes. Ms. Sennett Metzen is the Executive Director of Health Systems Engagement for Gilead Sciences. Welcome. And Dr. Pham Thuy, who's the Technical Lead for the Partnership for Health Advancement in Vietnam. Thank you all. Let me see what chair is left over. Who needs? Everybody got a microphone? Great. Well, fantastic. Meg, why don't you get us started, please? I know we've gotten some statistics already in front of us to realize why hepatitis elimination is such a big problem and why the value of eliminating it. Just please fill in some of the other data that you feel is important to give us a complete picture of this health burden, as well as some opportunities because of the feasibility of the interventions before us and some of the policies and other initiatives at WHO you have underway to expand access to these interventions so that we can accelerate progress toward hepatitis elimination.
All right, thank you very much. And it's really a pleasure to be here. And it's always good to be in a place where people are really focused on hepatitis, what it means for people, what it means for populations. And it's nice to see this collaboration with community primary care, as well as civil society, the coalition, as well as Devex and Gileads. So having sort of a private-public mix already here on the organization. So what I understand is, more data. I think what I would like to speak to is the fact that we are starting to get very good country-level data, but it's been difficult over the time. We have from our recent report in 2019, we have 350 million people living with some form of chronic hepatitis. That being, of which most of it is hepatitis B. And as you've heard, 1.1 million deaths and 3 million new infections every year. So it's a huge burden, and sometimes when we compare it to TB or perhaps TB has greater numbers of those who are not yet treated, but I think with hepatitis you have this long time frame from treatment, from knowing their diagnosis to the outcome, and we heard that in the story. So we're going to see not only right now what we know from the numbers and the new infections, 20, 30 years from now, we'll start to see that it will cost our health systems quite a bit to be able to manage and treat hepatitis B and C. So WHO put out last year a global health sector strategy. It went through the World Health Assembly. It was a second version based upon the first ever version, which was from 2016 to 2021. This goes from 2022 to 2030, and really outlined what are going to be the targets that we need to achieve to end hepatitis as a public health threat. And I think if you look at our strategies, overall the goal is to do this under the umbrella of universal health coverage, using primary care as the vehicle and ensuring health security. So with those targets, I think in many ways we're still looking to reduce new infections by 90% and deaths by 65%. But I went in there and checked there. We also made, for the very first time, absolute targets that we're looking for, which is a reduction of new B and C infections to less than 150,000 new B cases, less than 350,000 new C cases, as well as less than about 300,000, 400,000 apiece of Hep B and C deaths. So this means really a massive reduction of new cases if we implement the strategies. And I think what we did last year was really work on pilots for elimination that helps us enumerate, and we had 7 countries who went through those pilots, and certainly there are many countries who are making great strides in reaching some of those targets, certainly the incidence, certainly the programmatic service delivery targets, but I think the mortality targets are going to be tougher to reach. But I think we have seen already that places like Mongolia, who are making huge strides, are doing it through a UHC approach. They have integrated that into their UHC program, and I think those are the kinds of examples we're going to want to look at as we move forward and try to, I don't know, bring more hepatitis treatment to all who need it.
Thank you very much. Let's turn to Mohammed. Welcome again. First of all, how does it feel to be the director of a program that's achieved probably one of the most remarkable accomplishments in the history of public health, I believe, in the last 50 years or so, with the country that once had the highest prevalence of hepatitis C in the world, and now achieved remarkable reductions in that. And so I thought maybe just briefly you could give people an appreciation of that accomplishment, and perhaps also recognizing how the changes in your health system that you had to put in place to bring that about. You could also touch on that, as it relates to universal health coverage, please.
And thank you very much, Dr. John. I'm really grateful for having me today with this elegant panel, and allow me to respond to your questions, not briefly, because we had a long history for hepatitis eliminations and a lot of events that needs to be highlighted and described. And actually, the hepatitis C problem in Egypt started maybe since many decades, and the cause of the high prevalence of hepatitis C in Egypt was attributed to the mass treatment of bilharziasis, happened in 60s and 70s from the last century, using mass treatment with a famous drug at that time. It's called tartar emetics. It was used by injection with improperly sterilized needle, and this was the direct cause of the high prevalence of hepatitis C in Egypt. And actually, this was realized in Egypt with 2 demographic health surveys. The first one was carried in 2008, and the second one in 2015. And by the way, the second one, which was done in 2015, revealed that the viremic prevalence of hepatitis C in Egypt was at that time 7% of the Egyptian population from the age from 15 to 59. You can imagine that in 2015, based on the estimation of this DHS, we would have almost 4 million cases infected with hepatitis C and confirmed to be viremic. This was a huge number, and this was encouraged the Ministry of Health and the Egyptian government to set up the first national strategy for hepatitis prevention, diagnosis, and treatment, which covered the period from 2014 to 2018, and including a lot of very optimistic directions to improve the diagnostic capabilities and to ensure the proper access for treatment and to have a kind of starting of the screening campaigns. And this was associated also with a parallel efforts in the IPC measures, like adopting the blood safety and starting to ensure the injection safety procedures. And also this was associated with many milestones happened in Egypt. The first one, for example, is the establishment of the huge network of viral hepatitis treatment centers covering 27 Egyptian governorates. It's well-equipped viral hepatitis treatment centers with manpower and infrastructures like the BCR chain of machines, which allowed us to test thousands of blood samples of those who are infected with hepatitis C. And additionally, a great milestone was happened with the negotiation with the pharma companies in 2014. For the first time, we had access to the brand of sofosbuvir from Gilead with 1% of its global price. And this encourages the Egyptian companies when it comes to the generic manufacturing of the sofosbuvir and different direct-acting antiviral drugs, which happened for the first time in Egypt in 2016, which allowed for the deployment of millions of doses of hepatitis C medications and allowed us for the treatment of a couple of millions from the period of from 2014 to 2018. And at 2018, this is crowned by the mass national screening and treatment campaign, which was considered the historic and the largest nationwide population worldwide, and we were able to screen almost 63 million of the Egyptian population from the age group 12 and above, and discovered almost 2.2 million cases of chronic HSV and linked them to care. All this effort is done on governmental expenses. The medications, diagnosis, everything is free of charge. And also this is associated with a kind of a very comprehensive program. We do not cover only the HCV and we do not link them to care, but actually also those who are discovered to have liver cirrhosis, we link them to a long-term surveillance program for detection or early detection of hepatocellular carcinoma using a strict surveillance program and surveillance guidelines with a regular follow-up by ultrasound and alpha-fetoprotein to discover those who have HCC and link them to care with many of the new and innovative drugs of HCC. Last but not least, Egypt. I'm honored that Egypt was realized very early, even before COVID-19, that the fact that was the statement that by the Director General of WHO, no one is safe until everyone is safe. And for that reason, in 2019, His Excellency, the Egyptian President, launched the initiative for treatment of 1 million chronic HCV African patients. And this comes in a kind of realization of the fact that we should also transmit the Egyptian experience when it comes to the technical experience and infrastructures and capacities to the neighborhood countries from the African continent in order to bring this epidemic under control. That's all from my side, and thank you so much.
No, that's a lot. Thank you very much. Fantastic. Yeah. Let's turn to the Philippines. I know the Philippines has been very interested in implementing an agenda for universal health coverage, and just would like to hear some of your perspectives on how hepatitis prevention, testing, and treatment fits into that agenda, please.
So for those who are not familiar, the Philippines passed a landmark legislation, visionary, ambitious actually, of implementing universal health care for the country. The way that we defined what we want the universal health care to happen wasn't the typical cost coverage aspect of UHC, but the vision of having every Filipino matched to a primary care provider who will be providing all of the basic set of services that's due to them, and it will be that primary care provider who will navigate that patient across a provider network and a specialty network, and all without financial risk. So that's the main vision that we are set to achieve. And in this setup, there was kind of a threat to some vertical programs. So they were scared what happens to vertical programs in this setup. And the way that we explain what we want to happen is that we actually think that this strengthens, especially those that have been historically been forgotten types of diseases, because the patient encounter, especially at the primary care level, is supposed to be an opportunistic encounter wherein all of the necessary things have to be done. Even if a person comes in for an ear infection, all of the necessary services have to be done. And the financing mechanism will couple that. That's what we have to make. In the legislation, it also includes a lot of, I said, ambitious reforms about creating this healthcare network, this specialty network. We identified 16 specialties, and there's more upcoming that we want to set up all over a 7,000 island country, on a 20-year Philippine Health Facility Development Plan and a healthcare workers master plan. And also the expansion, of course, of our social health insurance. We started from around 40% coverage of our health insurance, which is PhilHealth. After the law was passed, it was automatic coverage for everyone. We're now at, I believe, at around 98%. But definitely, there's still a lot of room for improvement for the service coverage and the cost coverage of all of this. But I go back to the key reform of integration and the vertical program issue. Another thing here is that we want to use learnings from good practices of other programs and implement that for all other programs. So I have here a list of things that we've done specifically for hepatitis. So for prevention, of course, we all know of the whole mother and child agenda, and definitely the screening, the mother-to-child transmission screening and prevention using vaccination has been a core activity there. The screening for adult care is the one that we're trying to push for how to do. At least Dr. Janice and I was talking earlier, for the mother adult, it's clear. It's now a routine part of any delivery. But for the adult screening, we're currently, the approach is to do comprehensive assessment at the level of the workplace. But as mentioned earlier, there are some caveats to that we still have to figure out how to go about it, given that it might lead to discrimination and stigma. In terms of treatment, Joshi was able to allude to it earlier. We are exploring using our currently available HIV and TB treatment hubs to be access points for this. And that, that's where the integration happens. We use what's available for other disease programs, but now use it for the other disease programs, and especially if it's already available there. And in terms of health promotion, we've also aligned all of our historically vertical programs to a comprehensive school policy framework and a comprehensive workplace policy framework. So this is really the time for those that, especially diseases that were not given attention to previously. And especially because now we just have these major frameworks, it's easier also to communicate. So we do also have this feedback, especially coming from non-health actors, our labor groups, our labor agencies, our trade agencies, our education agencies, that previously they were so confused with having to implement 30-plus programs with 30-plus managers, talking to them, asking them to form technical working groups. It was very hard for them to understand. And now they appreciate us at the DOH trying to integrate everything into one comprehensive guidance of what it is that they have to do. And definitely the investments of one disease will now be able to expand to all other diseases.
Thank you so much for that overview. Well, let's turn to Senate here and talk a little about public-private partnerships. Gilead's been very active in a number of different ways in supporting a variety of activities related to hepatitis elimination over and above the drugs that they've made possible for therapies. So I thought maybe you would like to comment on some of those activities, and particularly as it relates to some of the work you're doing in the Philippines and Vietnam, please.
Sure. Thank you so much for the question, John. And yes, Gilead has a strong legacy in leadership in the area of viral hepatitis, and we've developed a lot of innovative medicines in this space. And what we've learned in the last 30 years is that in order for these innovations to reach those who could most benefit, that we have to partner differently, working with people affected and communities to really understand what the needs are and be able to create solutions around access. And putting people and communities at the center is very much a part of our health equity work that we do in the organization. And what does that mean practically? That means seeking out, listening, and learning from people like you, Ms. Joshi, to really build that space of collaboration. Now, to speak about collaboration, I want to talk a little bit about some of the work that we're doing in Vietnam and the Philippines, working with Harvard Medical School and the governments of Vietnam and the Philippines, and University of Philippines, Manila, to focus on service delivery and in the space of hepatitis, so decentralizing care from the tertiary level down to the primary healthcare level. And so as a company, we know really well how to work with academic institutions for drug discovery. It's something that is part of our core business. But where we are trying to build competency is how do we collaborate for service delivery innovation to develop different models of care. And that's something that's a little bit different than how we typically work. And so this partnership with Harvard and the partners is really about how do we develop these models of care. And one example is, what we've done in it's a 4-year partnership, and what we've done in the first year is follow, 63 people with hepatitis B and C to understand kind of the barriers that they face in the health system. And when we're kind of sitting and discussing kind of the framework and the structure of the collaboration, when we first had the discussion around, 1 year to understand the landscape, there was some eyes that in Gilead's side that were kind of just like, really? So, we're learning how to collaborate in this way together. It's a journey, but it shows that, putting the voices of people affected and the communities affected at the center is really how we're structuring this program and how we focus on kind of co-designing the different service delivery interventions and the models of care. So it goes to kind of speak to the way we're trying to engage in health systems and design these service delivery solutions. And then, for us as a company, we're evolving, and many companies actually are evolving the way in which we engage in global health. And my role, in fact, leading kind of health systems engagement and public-private partnerships is a new role at Gilead. I've been in this role about 8 months, and it's a testament and a signal that we are deepening the way that we want to engage in this space and the way that we want to work with different global health actors to address viral hepatitis and to reach our goals for 2030. So for us, one of the ways that we kind of want to kind of meet the challenge that you, Ms. Joshi, said to us like earlier, how do we, engage as a group more? And one of the ways is for us as the private sector to engage in the discussion earlier. Oftentimes, people come to us in discussions when we're talking about medicines and talking about products, but we want to work in this way that starts the dialogue earlier around service delivery innovation and how we can identify new models of care. Thank you.
Thank you. Let me turn to Dr. Tui. We've heard hepatitis at a personal level, a global level, a national level. I'd like to hear from a subnational level in your province is some of the challenges you're facing. And, we talk about health equity, and I think in your case, the challenges of providing care for a rural population. If you just give us your thoughts, please.
Thank you for your questions. We are happy to be here and to share our work in Vietnam. So in Vietnam, we work with Thái Bình province, which is in northern part of Vietnam with a population of close to 2 million of people, mostly farmers and workers with very low income. So the estimated prevalence of HPV infection in Vietnam is about 7% of the population, and HCV is 1%. So, but despite of that, only very few people can access the treatment. So very far from the WHO 2025 target, you know. So the community and even health staff are not well informed about hepatitis B and C. What is the challenge that we see? Most people access care at the provincial hospital, not where they live, you know. And they are seen by specialists in infectious diseases. Many, even after diagnosis, they cannot access the treatment, and some already on treatment, they quit treatment because of the challenges. You know, so from perspective of health facilities, the challenge we see is the shortage of the human capacity, limited access to laboratory testing, and lack of antiviral availability at affordable cost. Above to that, we may need a more simplified care pathway so that we can do it at the district level, primary health care level. The policies and directions on integrated model of care to reach larger population and to reach WHO target on hepatitis eliminations. Besides that, the service must be integrated into the, routine care so that it's effective and sustainable at our, So for the partnership, during the past year, we conducted a baseline assessment to help understand better the strengths and gaps of the current hepatitis system in the province. Most importantly, we did a study on the patient journey to identify enablers and barriers to care at each step of the patient care journey. This April and May, we started the co-design phase to bring together all related stakeholders, including frontline healthcare providers, provincial health managers, and representatives from the hepatitis affected community to design a person-centered model of care at the province. In the next few months, we will work on setting up the new model at district level. With the working is being carried out, we can see that our public-private academic partnership with the Taiping Department of Health, Gileads Sciences, and Harvard Medical School is a unique collaboration. Equally important is our partnership with the community in Taiping. So each party brings valuable strengths and experiences. So our work is being still carried out, and we still have years to go together. But we look forward to sharing the results of our project and also the lessons learned of our partnership to all of you.
Thank you so much. Fantastic. To solve a problem, you have to recognize you have one and then start developing a solution. It seems like you're off to a good start in that regard. There's a number of areas touched on in the conversation here. It brings to mind for me the various guidance documents from WHO that's really promoting delivering services for hepatitis elimination throughout health systems. And so I want you to, you may have other comments, but I would like for you to comment on those to help people be aware of those documents.
Yeah, sure. Thank you. And, I think, can you hear me? Yes, thank you. And yes, I'm really inspired by what I've just heard in terms of what's happening in the public-private partnership in Vietnam, but also the deliberate approach Philippines has taken to integrate. And I think these are the kinds of things that our Director General Tedros really wants happening everywhere. And I do think that does come, you've done something very nice of being able to ensure that your disease-specific programs are part of the solution. And because, primary care is a delivery mechanism, but you also need the elements and the, what one would say, the tools from the disease programs to make that delivery work. And so from WHO's perspective, we've had a longstanding development of guidelines, hepatitis C, hepatitis B guidelines. And last year, and maybe a year and a half ago, there were guidelines on hepatitis C that brought out some of the new areas of service delivery. Number one, we have guidelines now on self-testing for hepatitis C, which I think helps to bring this closer to home, which essentially is what you're trying to do, and a person-centered approach. There was also a large body of work that was done collaboratively between WHO, FIND, and a couple other partners in Vietnam and in other areas that helped to develop what are the specific approaches for decentralization, models of care. So we have a guideline that outlines for hepatitis C, task shifting, bringing the services out of a centralized hospital into the primary care setting, into the facilities in the districts, as well as working on decentralized testing, as well as integration and, where appropriate, actual, approaches for like, index testing, or not index testing, but testing that then promotes other testing. So you can do much more in the primary setting, and multiplex testing. We're working on the same regard for hepatitis B right now. We've just gone through a guideline process, and our team out there in the audience has been leading that. And soon we're very much looking forward to a simplified approach for hepatitis B as well. When you think about it, hepatitis B, 10% of the world knows their status or have been tested. Hepatitis C, 22%. That comes up with hepatitis B, less than 2% are on treatment. Hepatitis C, 10% or so. So we have a huge amount of work to do, but by making it person-centered and decentralized and removing those structural barriers, we'll be able to, I think, deliver more. And certainly, I do think that hepatitis C and B are the 2030 targets we should be able to make, and we need to have access to products that are within scope and can be purchased. And if you haven't heard, there's been some access prices last week that were announced. Access prices for hepatitis B drugs for $30 per year. Access prices for hepatitis C treatment and cure of $60 per year for low and middle income countries. So these are the kinds of things that we want to ensure get out to programs that need those access prices to be able to really scale up.
Thank you so much. So you're beginning to hear the feasibility of implementing these vaccination, testing, treatment, and some of the financial barriers are dropping away, as Meg just gave examples of. And what comes up increasingly is we need more national commitments to hepatitis elimination. And you have an excellent example from Egypt. And you also heard Dr. Hassani mention your work within Africa to promote more program development. But you've also been working, at the global level at the UN to develop a UN group of friends to eliminate hepatitis. And I wanted to see if you wanted to make a few comments about that, please.
Again, thank you very much, Dr. John, about this. And the problem of hepatitis, I get that we need a lot of coherent efforts and more harmonized actions, either between the governments, the states, and even different stakeholders works in the field of hepatitis. And the UN Group of Friends is a kind of extraordinary corridor that lead to a more comprehensive vision and more joint actions between the diplomatic pathway and the health leaders, advocacy, and different things. And for sure that every effort we are doing through the UN Group of Friends will finally fit on the WHO targets of hepatitis elimination by 2030. I realized that we have a lot of challenges when it comes to starting from the political will and the actual realization of the problem itself and the pooling of resources and mobilization of extra resources to fight the problem itself, and also how to build a concrete roadmap for hepatitis elimination fitting for every country module. Through UN Group of Friends of Hepatitis, which we are honored to chair for the first year, we have a very nice vision to bring the problem of hepatitis on table and to put the diplomatic pathway together with the health pathway in order to put this concrete vision in front of all the health leaders and the political leaders to take over the problem in its proper way. Otherwise, we will reach to 2030 without significant improvement of the indicators of hepatitis when it comes to infection rates, mortality rates, and everything. We need to bring this problem to the higher level. And I just discussed with my colleague Fomni about His Excellency the President Sisi, the President of Egypt, put the problem of hepatitis C on top of his working agenda. And he followed vigorously the progress for hepatitis elimination and treatment. Not only this, but the sustainability of this issue. Because the idea is not to reach to having, for example, an access to treatment and to diagnose people, but actually there's a lot of hectic things that needs to be adopted by every country when it comes to the sustainability itself. How can you prevent the incident cases of hepatitis? How can you ensure you are in a proper way for achieving the mortality targets? We're working extensively with colleagues from WHO in the hepatitis elimination dossier of Egypt. And we are shifted from the country of high prevalence of hepatitis C to be the first country asked for the validation for hepatitis C elimination. Thank you.
Thank you. We're almost out of time, but I did want to go back to the Philippines, and Meg was complimenting you on a very comprehensive, engaging approach. And and since we started off with the community voice, and it's very important, I wanted to see if you could take a few, less than 1 minute, and just mention about how is your Ministry of Health working with civil society organizations like the Yellow Warriors, please?
So I sometimes think it's a culture thing, like Filipinos being among the friendliest people you'll meet, but it's innate in our culture to really be involving yourself with the others. We have a word for it, like kapwa. And the way that the Department of Health works has actually already, since time immemorial, or even included civil society as part of the process. So for example, in our policy-making process, they're always parts of our technical working group, even in high-level councils. So for example, cancer, because we currently house our hepatitis activity under a cancer coalition. It's a national integrated council made up of heads of agencies, medical societies, but there's 3 seats there actually for civil society. So it's a deliberate, and it's always part that civil society is part of work. And we partner with them all the time for advocacy, especially in giving the information of how to access our access programs, because they're able to reach the unreached. So I think it's deliberate, but we're very fortunate that it's part of our innate being that that's how things work. And I also think that's why we're kind of agile in our processes and in our visions for what we want to happen, because we always get those lived experiences when we make our policies.
Thank you so much. Well, thank you all for a very engaging and informative panel. Hopefully, for those that are not working on hepatitis elimination, like we are, I hope it's beginning to dawn on you the size of the problem, but also how this problem can be dramatically reduced because of the very highly effective and strategies and interventions, vaccinations, testing, and treatments that we have available. And you have excellent examples here on the stage from Egypt, Philippines, and Vietnam, how they're taking actions to put those in place to have a dramatic impact to improve the health of their population in a very equitable way. And that's what we're seeking to do collectively to get more countries on board and have that national commitment. There's a saying in disease elimination that national commitment is as important as technical know-how in achieving elimination. And that's why it's really important for everybody that's in this room and that's watching virtually, or maybe watching this after the fact when they see this, is to really call on you to get involved and for us to grow a global coalition. That's what we're all about at the Coalition for Global Hepatitis Elimination. Create a forum for information exchange, lessons learned, generating knowledge, and then creating the advocacy to bring the partners to the table that have the know-how and the resources to accelerate our progress toward hepatitis elimination. So please go to globalhep.org and sign up and learn how you can get involved. For those in the room, you have a call to action, just so you will know how to get started. We're recognizing that universal health care coverage is on the agenda for WHA this year. It's a part of a high-level meeting that will be that will be convened at the United Nations, and we want to make sure that hepatitis, is part of that. So please stay tuned for that and be ready to step up and be part of that advocacy. For the call to action, we have two parts. Whether you're a funder, a program manager, civil society member, clinician, or just on your own individual, we ask you to seek to advocate for equitable access to hepatitis B, hepatitis C prevention, diagnosis, and treatment services within a UHC framework, with the removal of patient copays and other barriers that stand in the way of people receiving these life-saving interventions. And then secondly, really to seek a people-centered approach for the integration of hepatitis B and hepatitis C within primary health care, which includes identifying, elevating, and amplifying the voices of persons living with hepatitis and their local advocacy groups. So please join us and get involved. And as Meg says, this is one of the most feasible disease elimination programs underway right now. So if you want to be a winner, join us and join our celebration in 2030. Thank you very much. I'll turn it over for closing comments. Thank you very much. And thanks. Let's give a round of applause to our panel, please.
Thank you, John, and thanks for the call to action to all of our panelists, esteemed speakers. Thank you very much. It was a really engaging session. And also a big thank you to Ms. Joshi and to Dr. David as well. Now, I'm afraid that's all we've got time for. We could probably talk for another hour, but I wanted to give a big thank you to our partners, Gilead Sciences, Harvard Medical School Program in Global Primary Care and Social Change, the Coalition for Global Hepatitis Elimination, and of course the World Hepatitis Alliance. So thank you for your input, your support in sponsoring and convening this very special session. And to our audience, online around the world and here in the room, here in Geneva, stay tuned to Devex at WHA 76 tomorrow. We've got another full day of coverage from our summit, including two very special ecosystem events, the first in partnership with MSD for Mothers, as well as the Country Connector on Private Sector in Health. That's on how the private sector can advance equitable access to maternal health care. That's here at the Intercontinental Hotel in Geneva and live online from 8 a.m. CET tomorrow. The second ecosystem is on digital solutions in global health in partnership with Medtronic Labs, live from 11 a.m. CET here at the Intercontinental and live on online. So thank you very much. We've got a whole host of coverage the rest of this WHA week. Thanks for joining us this evening. Have a lovely rest of your evening and see you tomorrow.